Now, as we get ready to treat our patients, we have to have a systematic approach of treating patients. Now that we know the anatomy and we know the physiology, but when we work with neurological patients, there's a lot of questions that we have to ask first. So some of the questions that we can ask are, what is the most appropriate way to examine the patient? How much time should be spent on documenting functional ability versus evaluating underlying impairments? What criteria should I use in deciding what the priority problems are? How do I establish goals that are realistic and meaningful? What is the best approach to intervention and the most effective way to structure my therapy sessions? So what are the most appropriate outcomes? So when you ask all these questions, you're thinking, oh my gosh, but this is the reason that we need some kind of framework. And what we call this in therapy is called a conceptual framework. So a conceptual framework is a logical structure that helps clinician organize clinical practices into a cohesive and comprehensive plan. Context in which clinical information gathered and interpreted. So basically you have a systematic way of organizing your thoughts and not just haphazardly going about it. Okay, so you have some kind of framework. When you're ready to build a house, you don't just get all the materials and then just hopefully kind of throw it together and hopefully it works. All right? First you put the concrete, then you put the slab, then you put the frame, then you put the electricity, the wires, the plumbing. I mean, there's a lot of steps into building a house. Same thing with building a comprehensive plan to treat a neurological patient. Now, conceptual framework concepts. There's a few of these out there. There's a model of practice. There's a model of function and disability. There's a hypothesis-oriented clinical practice. There's principles of motor control and motor learning and evidence-based clinical practice. So there's 5 ways that we can look at a neurological patient. Now, none of these are incorrect. You just have to choose which one you like. And when you do your case studies, I want you to know which method you're going to use for treating your patient. So again, like the theories that we talked about, there's not one conceptual framework that is better than others. So the purpose of this chapter is really to consider all the elements that contribute to a conceptual framework that we'll find useful and we can use with evidence-based practice. And then in the end, we'll talk about task-oriented approach. And a task-oriented approach is used in the later chapters as a framework for retraining posture, retraining mobility, and upper extremity control in a patient with a neurological deficit. So let's move on to components of a conceptual framework for clinical intervention. So you have 5 key elements or concepts. So you have a model of practice. That's the method for gathering information. Okay, so you're gathering information. You have a model of function and disability. You're looking at the person as a whole and minimize injury, strengths, and limitations. A hypothesis-oriented clinical practice, basically it's a way of explaining facts like having test A, B, or C, and you're just testing assumptions. Principles of motor control learning is how do you model, how do you relearn skills. And evidence-based clinical practice is sufficient amount of data that is considered well designed and evidence supports practice. So this is good. I love evidence-based clinical practice, and a lot of the PT schools are going to evidence-based clinical practice because there has to be some kind of research based upon what we do. You can't just say, oh, it's good because it's good for you. No, that doesn't work. Now, as we look at the different case studies that we have in our class, Janice, Jean, Bonnie, they all have different diagnoses, right? So one has acute stroke, chronic stroke, Parkinson's, multiple sclerosis, and our 2 kids, they have cerebral palsy. But even though they come with different diagnoses, we still need to have a conceptual framework to look at them in the same way and be able to systematically identify each patient's motor control problems. And although their solution may be different, ways that we can examine and have a systematic way can be the same. So, the models of practice, the American Physical Therapy Association Model of Practice, you have 5 elements. And the 5 elements are exam, eval, diagnosis, prognosis, and intervention. Process is an interactive one. Now, if you look at this, management process is comprised of 5 elements. So you have an examination. The examination will lead to an evaluation, okay? And the evaluation will lead to a diagnosis and a prognosis. And based on the diagnosis and the prognosis, we're going to come with an intervention. Now, if that intervention doesn't give us the outcome that we want, then we have to go back to the evaluation and say, where did we go wrong? Or if the evaluation says, okay, we need maybe to examine it in a little different direction. Now, let's say it all fails, then we need to refer them back and say this is not working. So you see how it's an interchangeable unit, this model of practice. But you starts with the referral and then starts with the evaluation. Okay? But the evaluation, now what's the difference between evaluation and examination? So it's very important to understand the difference between an examination and evaluation. So you always start with the examination. And the examination will consist of a history, thorough medical history. Then you're going to do an objective test of a systems review. You're going to look at their somatosensory. You're going to do vision, vestibular, motor system. How do they plan actions, modifications, their cognitive system, the MSK system. And you're going to do tests and you're going to do measurements. That is a clinical exam. Okay. In the history, you're going to obviously look at the medical history, the demographics. You're going to interview the patient, ask what their goals are. You're going to do a systems review, see if there's any comorbidities. And of course, there's lots of tests and measurements. You can test balance, you can test circulation, you can test gait, you can test joints, range of motion, pain, posture, reflexes, self-care, etc., etc. And based on that examination, you're going to come up with the evaluation. So the evaluation is the next step in the APTA's patient-client management process, and that's defined as the process of making clinical judgments based on the data that's gathered. So you did the exam, right? Did the history, systems review, test and measurement. Now you come up with evaluation. So you interpret the individual's response to the test. You integrate the test and measure data with other information. You determine the diagnosis based on your examination. You determine prognosis. You set goals, and then you develop a plan of care. Okay, but it all starts with the examination. Just another image here. Now, again, we have to look at these many times so you get it. So the first practice, American Physical Therapy Association Model of Practice. So examination is obtaining data to form a diagnosis, prognosis, and plan of care. So there's 3 parts in the exam. You take history, age, sex, living environment, family, social history, activity level, ADLs. Then you review relevant systems, MSK, neuro, communication ability, language, and then you perform tests and measurements. There's 26 categories, and that can include balance, gait, pain, posture, range of motion. So, and I'm going to teach you not all of them, but a significant chunk of these balance tests and these gait measurements. Again, the American Physical Therapy Model of Practice, the evaluation is now you're going to make clinical judgments based on the data gathered during the exam. So it reflects severity and duration of current problem, presence of coexisting conditions, stability of conditions. So all those factors will go into the evaluation. Then, based on the evaluation, what are the primary goals of the clinician and non-clinician during this process? How is the process likely to differ for the clinician versus the non-clinician? How can these two different professional groups interface? So the next model of practice we're going to look at is diagnosis. Now the diagnosis identifies impact of a condition on function at a level of a system and level of a whole person. So now there's a big difference between a PT diagnosis versus a medical diagnosis. Okay, so Parkinson's disease is the medical diagnosis, but the physical therapy diagnosis would be muscle weakness or gait disturbance. There's nothing that we as physical therapists can do about Parkinson's disease, but we can as physical therapists work on the muscle weakness and the gait disturbance. That is the physical therapy diagnosis that we're working on. Okay, so we can have two patients that have a medical diagnosis of Parkinson's disease, but they can have a totally different physical therapy diagnosis. Does that make sense? And that's very important for you to understand, because a lot of times people just treat the medical diagnosis, but we need to treat the physical therapy diagnosis, because let's say you have two Parkinson's patients and one has gait disturbance and range of motion issues, but another one has muscle weakness. They're both Parkinson's disease medical diagnosis, but their physical therapy diagnosis is different. And how do we come up with a physical therapy diagnosis? Well, those are signs, symptoms, syndromes, categories of problems. Okay, and the purpose is to direct our treatment. So if you have someone that has gait disturbance, we're going to work on gait. If you have someone that has muscle weakness, we're going to work on strengthening. If somebody has range of motion issues, we're going to work on range of motion. So that will help direct our treatment. The prognosis is basically how well are they going to do. Level of function independence patient expected to achieve following intervention and amount of time required to get to that level. The plan of care, those are goals. Predicted level of optimal improvement, intervention to be used, duration and frequency of interventions. So when you did your first assignment, you guys wrote some goals, but now I'm actually going to show you how to write a real specific goal. And for insurances and for your patients, you need to learn how to write really good goals. Okay? So what I want you to do is I'm going to give you some time here, and I want you to write 3 disability goals, 3 functional goals, and 3 impairment goals. And I give you an example of all 3. So disability goal is outcomes related to recovery of participation. Patient able to return to playing 9 holes of golf in 3 hours. Okay, those are our usually long-term goals. It's going to take a while. Our functional goals is reflect recovery of performance important to functional task and ADL. So patient able to reach into a cabinet and put away an 8-ounce glass in 1 minute. Do you see how specific that is? What is the patient able to do? What are they going to do it? And how long is it going to take them? Okay, so if you don't have that in your goals, then that's not a measurable goal. If you just put patient able to reach into a cabinet, well, I don't know what they're reaching and how long it's going to take them to do it. So make sure that it's time specific, very specific. An impairment goal would be the simplest, and this is where you start. So if somebody has knee issues, our impairment goal would just be to improve knee flexion to 90 degrees. Okay, but you can also make it time frame. Improve knee flexion to 90 degrees in 2 weeks. Okay, then you can even make it even more specific. Improve knee flexion to 90 degrees so in 2 weeks so patient can go up and down stairs. All right, so that's the way I want you to think. And in your book on page 139, it has essential components of a well-written functional goal. There's the A, B, C, D, E rule. So A is the actor, so who will carry out the activity. B is the behavior, description of activity. Example, will walk. Condition, circumstances under which the behavior is carried out. D is degree, the quantitative specification of the performance. So this is 8 out of 10 times, in 4 minutes, 3 blocks, 1 mile, 500 feet. And how long? Expected time. How long will it take to reach the goal? Okay, stated in weeks, months, or alternating. So you can group that up into long-term and short-term goals. So here's a good example. Patient will be able to walk at home with a walker and supervision 500 feet in 2 minutes. So the actor is the patient. Behavior, what will they be able to do? They're going to be able to walk. Condition under which? Well, what are they going to do? At home. Degree, what is it? They're going to actually use a walker. Are they going to need supervision? Yes. And how long? It's going to take them 500 feet. And how long is it going to take? 2 minutes. Okay. So you have to have all these components, A, B, C, D, E, to write effective goals. So let's practice this. And I want you to write 5, and everyone's going to share some. The prognosis is what is the individual's capability for change, which identified impairments are changeable, which impairments are permanent and therefore not amendable to change, what goals and outcomes should you establish for your patient and client. The goal is useless unless it's functional. So prognosis is very important, and like I was telling you, someone with a chronic stroke for 3 years, their prognosis may not be as good. It might be fair versus someone that had an acute stroke and they started therapy right away. So their prognosis may be good. Okay, so it just depends on a lot of factors. Now, from the Model of Practice, American Physical Therapy Association, what about intervention? So what do? Intervention is going to be the purposeful and skilled interaction of the therapist with the patient or client instruction, airway clearance techniques, assistive technology, and biophysical agents. So that's all the things that we can do. What else can we do? Functional training and self-care and domestic work, community, social, civic life. We can do skin repair and protection techniques. We can do manual therapy techniques. We can do motor function training, and we can do therapeutic exercise. When you go to physical therapy school, this is all the stuff. The intervention is what you're going to look forward to, and this is what you're going to learn. So the intervention, again, has to be purposeful and skilled interaction of the therapist, trainer with the patient. Interventions are organized into 9 categories. So those categories would be patient or client instruction. So you got to tell them what to do. Make sure the airway is clear. Is there any assistive technology we need to use? Biophysical agents, heat, cold, functional training and self-care and domestic work. We need to make sure the skin is intact. If not, we need to protect it. Manual therapy techniques. We're going to do motor function training, and of course therapeutic exercise. So that is all the options for our intervention. So think about this. If someone that's in the hospital bed, well, maybe our goal is just to do airway clearance techniques and assistive technology. But if somebody comes in an outpatient clinic, maybe we want to do manual therapy techniques, biophysical agents, and therapeutic exercise. So depending on which category they're in, we can do that. And maybe in the hospital, we just want to do a skin care and repair because they were lying on their back too long and someone forgot to change them. Right? All right.